Good afternoon, everyone, and thank you for joining the online workshop webcast today on Making Science Stick, Developing the Knowledge Translation Plan. Our presenter this afternoon is Dr. Melanie Barwick from the Hospital for Sick Children in Toronto, Ontario. Dr. Barwick will discuss developing a KT plan in order to increase the impact and reach of research findings to a variety of audiences. I'm your host, Joanne Starks, and I'm with the National Center for the Dissemination of Disability Research, or NCDDR, based at SEDL in Austin, Texas. I'll be moderating today's webcast. I want to thank our partners at Baylor College of Medicine for providing technical support for the webcast, and the captioning company for real-time captioning. Both are located in Houston, Texas. A reminder for our participants, the PowerPoint file and a text version of the slides are available on the NCDDR's webpage for webcast number 30. Go to www.ncddr.org and look for the yellow box in the middle of the homepage. There is a link to read more about the webcast. And if you go to that page, you can download materials. Please do remember these materials are copyrighted, and you must contact Dr. Barwick to ask permission to use any of this information later. You may submit questions at any time during the webcast today, and we will do our best to respond to them as time allows. Please send your question to webcast@ncddr.org. We would appreciate it if you only use this address for questions for our presenter, not for technical support problems. You may also call in your question or call for technical support. Our toll-free number in the U.S. is 800-266-1832. This number is both voice and TTY capable. If you are outside the United States, and we do have quite a few viewers today from Canada, please call 512-391-6517. Some important technical notes to keep in mind. The most common technical problem is that the Windows Media Player or Real Player window might freeze up or stop advancing the slides. If that should happen, please close the player and just open a new player window. The webcast will start up right at the current spot in the presentation. So just make a quick mental note. If the window freezes up, close it and open a new window to pick up right where the webcast is. If you should have other technical difficulties, please call 800-266-1832 or 512-391-6517. You can find these numbers later by clicking the Additional Information tab under the Presentation Slides window to the far right. We would appreciate your feedback today by filling out a brief evaluation form at the end of the webcast. If you click the Downloads tab at the bottom right-hand side of your Windows Media Player or Real Player screen, you will find a direct link to the evaluation form. I will remind you about this again at the end of today's presentation. And also a reminder, there are no pre-approved continuing education units for today's webcast. Now I'd like to introduce our speaker. Melanie Barwick, PhD, CE Psych, is a registered psychologist with a primary role as a health systems scientist in the Community Health Systems Resource Group at the Hospital for Sick Children, or Sick Kids. She is an associate scientist and inaugural director of knowledge translation in the Child Health Evaluative Sciences program of the Sick Kids Research Institute. And she holds appointments as associate professor in the Department of Psychiatry and the Dalla Lana School of Public Health at the University of Toronto. Dr. Barwick is the lead author of the Scientist Knowledge Translation Training course and Knowledge Translation Professional Certificate. Her program of research is in implementation science. I will now invite Dr. Barwick to begin her presentation. Dr. Barwick?
Thank you, Joanne. Good afternoon, everybody, and thank you for joining today. I'll endeavor to try and remember to speak at a steady pace and not too quickly. Can we have slide 2, please? Today, what I would like to cover in the time allotted is an overview of KT plans as they begin to be a proposal requirement across the world. Secondly, the basic components of a KT plan, followed by some evidence-based knowledge translation strategies, such as we know them to be at present. I will talk about some innovations and the issues of stickiness, or the concept of stickiness, and how we might consider bringing that into our knowledge translation activities. And finish off with an overview of the knowledge translation planning template that was developed here at SickKids in my team. Slide 3 just introduces the KT plans as a proposal requirement. Slide 4 gives you an overview of implementation science funding worldwide, courtesy of Jacqueline Tetreault in Ottawa at the Canadian Institutes of Health Research and her colleagues. Internationally, implementation research, KT research, is a recognized area of funding within certain healthcare systems. And as we can see here, it's grown quite extensively over the last 10 years. In countries where there is a name-dedicated funding stream, such as Canada and Australia, the research area has a higher profile with both researchers and with clinicians. In Canada, our main health funder, Canadian Institutes of Health Research, has been an important driver of knowledge translation and implementation science in several ways. They have a knowledge translation branch. They have operating and strategic funding that require knowledge translation plans for several years now, or at least request them in addition to the scientific description of the proposal. They provide strategic funding in knowledge translation, and they have also provided research grants for the training of new scientists in this area. Slide 5, please. Health research funding agencies have supported and promoted KT internationally, according to the Tetreault article in the Milbank Quarterly. We can see here in the first table in the upper left quadrant that a knowledge translation plan is a requirement in 73% of the 33 organizations that were studied in this particular project. 61% encourage partnerships with stakeholders, and 45% ask the scientists to define KT target audiences. Table 7 in the lower right-hand quadrant of the page depicts that agencies, research funders, fund KT requests for applications 36% of the time, and they are also funding teams of investigators a third of the time. A smaller percentage are funding research shares. So we can see that globally the activities of research funders are driving research in implementation and knowledge translation. Can I go to slide 7, please? The key components of a knowledge translation plan have been written about by several investigators and people working in this area, Paula Gehring, amongst others. Essentially, one needs to start with a consideration of what your KT goals are. Much has been said about how knowledge translation can only occur when there is a body of research evidence. And while I would agree this is the case in certain circumstances, it isn't always so. There are many goals that we could be focused on in knowledge translation. The knowledge translation goal might be, for instance, to develop awareness of a particular issue within a stakeholder group or audience. It may be to prepare for readiness for change. It may be to actually elicit behavior or practice change or change in policy. I suppose what I think is important here is that if one's goals are to change behavior or to change practice or affect policy, this is where you need to have a body of research evidence that has rigor and high quality. But that doesn't mean that there are circumstances where we wouldn't want to share research knowledge just for knowledge's sake on the basis of a particular study or a smaller body of work. Consider that a research article, a journal publication, is one instance of knowledge translation for a single study. So we already do this quite significantly. The second component of a knowledge translation plan is to consider who the target audience is. With scientists, this can be challenging, particularly when they have developed somewhat of a tunnel vision with respect to who they're doing the science for. Clearly, we are very good at training scientists and encouraging seasoned scientists to communicate with other researchers, and we have academic currency that supports this sort of knowledge translation through our peer-reviewed publications. The challenge sometimes for some researchers and for others who are working in knowledge translation is to consider who the other target audiences may be, and to think through who might be the end users of their research, who would be the people in the best position to apply this information for health or well-being or other outcomes. And what we have learned through the research and through anecdotal report from practitioners in the field is it's important to consider how you will engage your audiences and when you will engage your audiences. How we will talk about in several slides down the line here in terms of KT strategies. When you engage your audiences is very important to consider. There has been probably much more effort put in to end-of-grant knowledge translation, so the efforts that we make as researchers to disseminate our findings, to spread our research results. Less attention has been paid to engaging our end users or people who may have some input into our research or program of research at the early stages when we're conceptualizing our research project. And that can be very useful, although it also creates a situation of pushback by some researchers who feel very protective of their methodologies and their designs and don't necessarily want to hear or amend them or hear what people might recommend in terms of changes. I'm going to give you an example in a minute about why it's important to engage early. The fifth consideration in a KT plan is thinking through what your main messages are. And I think the important consideration here is to recognize that main messages for one target audience may be different in some elements, both in format and also in focus, than what they may be for another audience. What you want to share about your research findings with parents will be highlighted somewhat differently than perhaps what you may want to share with policymakers or with other researchers. So the notion of one plain language product that describes your research results as something you might use with multiple non-academic audiences is not necessarily the best approach to take. You will still want to tailor and consider people's preferences for how they want to get their information in terms of format, but also considering for each audience what is important for them about what you learned. It's not so much the perspective of the researcher in terms of what do I think is important about my research, but rather what will parents think is important about your research? What will nurses or practitioners in another area? What will policymakers? What element of this is the golden nugget for them? And getting to know your audiences ahead of time will help you arrive at some aha moments, if you will, about what is going to be important in your research for different audiences. One has to also consider what KT strategies you will use, and we will discuss those later in my presentation.
Excuse me, Melanie, we seem to have a little bit of a problem with your speaker. It seems to be clicking in and out.
Oh.
So I'm wondering if maybe your hands-free might be better.
Okay, I'll go to hands-free.
Okay, sorry to interrupt you.
That's okay.
Thanks.
All right, I'm on hands-free now, so you can let me know, Joanne, if it still doesn't work.
Okay. Sounds good right now.
So The other thing that we have not given a tremendous amount of consideration to in knowledge translation research or practice is the whole notion of implementation. We have focused a lot in clinical trials, comparing one KT strategy to another arm, for instance, and looking at outcomes. And what you will notice in a review of KT research to date is very little is said often about the process of how the KT strategies were implemented. We know very little about, say, how to implement evidence-based interventions or evidence-based medicine into different contexts, and this is really a burgeoning new science. I suppose where it pertains to building a KT plan, you want to make sure that you're not just identifying a KT strategy, for instance, letting people know that you'll hold a workshop or that you will train clinicians. You want to then go further and describe how you will implement that training, what sorts of pre-training preparations you will make, what your training will look like, what your fidelity measures will look like after you have trained, and how you will continue to support your practitioners, just as an example. And one of the last considerations is to think about what impact are you going for. You've declared what your KT goal is, who your audiences are, how and when you will engage them, what you think you may like to say to them based on your results, what strategies you will use, how you're going to implement them, but you're not done until you can say something about whether you met your KT goal. What impact did you actually have? This is a bit of a like sticking Jell-O to a wall because we don't have any universal indices of impact, and it's going to be just as specific to your particular project, say, as your methodology needs to pertain to your research question. And so it's very difficult to give a sort of a set group of indices that will measure impact. It's going to need to be thought through for your specific project. And lastly, to consider what resources are required to enact and implement your knowledge translation plan. In Canada, our Canadian Institutes of Health Research actually provides quite a bit of funding for KT resources and budget items. I'm not sure what the situation is in the United States, but it's certainly a wonderful facilitative feature to have. Can I have slide 8, please? Considering who your audience is, as I said, is important. You need to think about who needs to hear your message, how well do you know your audience. One of the important things we often don't think of is how prepared your audience may be to make decisions based on the evidence. And so one important element to consider and that you can actually measure and plan for is readiness for change, both at the individual practitioner level and at the organizational level. But it's an important consideration. Oftentimes we think we've really accomplished a participatory aspect of our research by striking an advisory group where people can contribute to the research as it evolves, and we think we've covered all of the bases. One of the things to consider when you have an advisory group is not only whether they're prepared to make decisions and have readiness for change, but do the individuals who sit on your advisory have sufficient clout? Are they well positioned within the organization to take information back from the research team to share throughout the organization and to think through how that information, research-based evidence, might be used within the organization? So it's important to consider who within an organization is going to represent on your advisory team if you have one. It's important to know what the barriers are for knowledge uptake. I work in the field of child and youth mental health, working with service providers in behavioral health who may be very well intentioned to implement an evidence-based practice, but maybe perhaps has to contend with a year where they are meeting their accreditation review, or they are having a high staff changeover, and there may be other issues going on that perhaps would be a significant barrier to consider for a knowledge translation activity. The other thing to consider is what existing networks or knowledge conduits already exist for the audience you're trying to reach. It used to be that many of the earlier research projects with KT plans would call for the development of unique websites, brand new websites. And I think now as we look towards developing good partnerships and thinking through our knowledge translation opportunities right from the beginning as we develop our proposals, we give ourselves an opportunity to see who we want to reach and how we might reach them and what partners we might engage with that would help us meet those audiences. So this may be voluntary health sector organizations or NGOs or just simply other systems or other organizations that could help us to meet our KT strategies, not just because they already have access to the audience you want to reach, but because they also have credibility with that audience, and they may also be able to leverage the expenditures that you would otherwise have to pay for yourself to reach those audiences. Can I have the next slide, please? So slide 9. What I wanted to say about the audience, and this will probably come as no surprise to those listening, is that we have, I think, surmised from practice and from research that one-size-fits-all communication strategies are rarely successful, and I've touched on this already this afternoon. We need to tailor our main messages to our audiences. We need to give people the information they need, not what we think they need. And I think you often see this in new researchers who are just so close to their research and so proud of their new accomplishment. It's difficult for them to take another's perspective to see what might be important to someone else about the work that they have done. You need to give yourself time to listen to an audience and what issues are important to them. I think it's still common for scientists to develop projects with partners and seek out those letters of participation and support from partners without really giving themselves time to develop a good relationship with those partners. A lot of this is about, social interaction and partnership, and whether you're working with other organizations, even with other groups of scientists, and most definitely when you're working with senior policy advisors and government, one needs to take time to develop these friendships, these relationships, which will serve as conduits of knowledge translation for you throughout the research process. You want to think about involving your audiences in developing, discussing, and delivering your research findings. Slide 10. When we think about how we can increase the utilization of our research, we want to think about the format, the style, the timeliness. But this in and of itself is not going to lead to research utilization. Who provides the information is as important as what information actually is provided. Sometimes the primary investigator for a research project is not the best person to be your broker, your knowledge broker, the person who shares main messages. And so some consideration of who on the research team or who amongst your partner organizations might be the best deliverer of specific research messages for your project. And as I've said, readiness for change and readiness for knowledge use is an important consideration. Can I have slide 11? One of the things to consider is, while we're often focused on practice change, that's certainly a lot of the research that's going on these days, we think of the practitioner, and it might be a school teacher, it might be a physician, it might be a mental health practitioner. We need to remember that these individuals sit in organizations. The things we've learned, for instance, in our research that are important to teachers who change their practice and also to mental health practitioners have to do with the characteristics of the practice to be adopted. They consider things like, well, what's the advantage to me if I change my practice and I take on this new way of doing things? How compatible is this with what I already do? How simple is it to do this versus how complex? And of course, the greater the complexity, the less inclined a person will be to change their practice. Teachers in particular like to have an opportunity to try out a new intervention or a new practice, and certainly they base a lot of their decision on whether or not to adopt on what other teachers have to say, more than what other researchers have to say, and they really value the ability to, or the opportunity rather, to observe a new practice in the works, as it were, being used and showing good outcomes. One also has to think about the characteristics of the exchange between stakeholders, what strategies, what level of engagement, when, what type of engagement. We need to think about how social networks influence diffusion and practice uptake. And one of the things I've learned in the last decade of supporting outcome measurement and practice change for the province of Ontario is it really behooves you to pay attention to the early adopters. There will be people who you will want to take on a new practice who will not be so readily inclined to do so. And oftentimes you can end up spinning your wheels. So my recommendation is to pay attention to those who have readiness and a vision and are ready to adopt new skills. And of course, characteristics of the adopting organization are also important. So factors such as leadership, motivation, competing priorities. One of the things that we've been studying recently is the role of consumer preferences, rather teacher preferences or clinician preferences for how they want to change their practice. And we've incorporated that into a model that we are testing in our current research. Can I have the next slide, 12, please? So this is just a schematic of the model that we're testing in our CIHR emerging team on knowledge translation for child and youth mental health. We are implementing motivational interviewing in 5 service provider organizations who provide mental health services for kids. And we've paid particular attention in a systematic review way to the evidence for motivational interviewing, not in terms of the outcomes it yields, but rather the training that has been done. So how successful is motivational interview training for health practitioners? We're paying attention to the context of these organizations, their readiness for change, and we are doing some conjoint experiments to examine mental health practitioners' preferences for changing their practice. We'll use all of these pieces of data or evidence as we develop an implementation plan for the training and the subsequent support of their use of motivational interviewing in practice. And our facilitation component will be the stages of change described by Dean Fixon and his group in Chapel Hill with the National Implementation Research Network. Next slide, please. When you think about how you will engage your audiences, we know that the strategies should fit audience preferences and that it's desirable that strategies involve active engagement. Slide 14 is just a depiction of a story, really, that I want to tell you about. It was an illustration, a story shared by Alison Hewitt, who was at the time the director of Safe Kids Canada, which is an injury prevention advocacy outfit associated with Sick Kids Hospital. And she told the story many years ago about her aha moment of why it's important to engage partners early. And this story had to do with years and years of research in reducing scalds in children. She described that over 300 children and elderly people with disabilities are treated in hospital annually across Canada for burn injuries caused by hot tap water. Hot tap water injuries are actually predictable and preventable. For decades, injury prevention advocates had urged that tap water be no hotter than 120 degrees Fahrenheit, and at this safer temperature it would take longer to cause a severe burn. But turning this knowledge into action in Canada had been a slow process. They conducted numerous public education campaigns to reduce risks through behavior change, and still the rates of tap water scald injury in Canada remained virtually unchanged. At one point, they realized, we could do a lot by engaging the Plumbers Union in Canada to be involved in helping us address this issue in people's homes. And they made these contacts. And she said, shockingly, she found that they were not so inclined to partner with them at this stage in the process. And she said she realized had she engaged them much earlier on as they were conducting research and really involved them as a legitimate partner with a vision to what they might accomplish in the knowledge translation aspect at the end of the research, they would have been far more successful. Next slide, please. And let's go to slide 16. In terms of measuring health impact, one of the frameworks, I guess it is, that I have found most useful, even though it doesn't speak to specific indices, is this framework developed at the Agency for Healthcare Research and Quality in the U.S. And it basically focuses the individual to think about what are the impacts I expect my KT plan or my research to have at the healthcare research base or on future research. And we're pretty good at that. We share our research findings well with other researchers. The next level is to think about what our impact would be on health policies and services, then on clinical practice, then on health outcomes. If you go to the next slide, 17, it's a bit of a busy slide that depicts Sullivan et al.'s indices. It's really a logic model that gives you an idea of how you might monitor and evaluate the impact of health information products and services. Now, this is a different sort of outcome. These are projects that have developed products or services or KT or brochures or summaries. And I've included it here so that in your own time you can go back and look at it to give you some ideas about how you might measure initial outcomes, intermediate outcomes, and so on. The following slide, 18, is a more detailed look at how they've conceptualized their audiences and the various indicators for user satisfaction, etc. And I think it's a useful framework if what you're producing are products or services and you want to measure spread, dissemination, and impacts in this way. Slide 19 and 20 give you a breakdown of how they have developed these indices for these various areas, and I'm going to skip through them. And I'm going to go to slide 24, please. So before I get into the KT strategies that have an evidence base, this is an interactive question, but we'll just do it in this monologue sort of way. Consider how many journal articles you would have to read per day to stay up to date. And you can probably see I've already starred one of the items here, but shockingly, one would need to read an estimated 25 number of articles to stay up to date in your field. This is not achievable, and I think one of the ways we're going to make significant strides in increasing capacity for research evidence use is in developing greater intermediary tools, some of which have already been made available here in Canada through the National Collaborating Centre for Methods and Tools, through health evidence, and different ways of providing research evidence to users in real time in ways that they can use right away. I think this is what's really needed. The journal articles will inform, certainly, but they are not sufficient to change behavior. So let's look at some of the evidence-based and innovative KT strategies. And again, with thinking of the time I have remaining, I may flip through these rather quickly and not go into great detail. Slide 26 gives you an overview from Richard Grohl and Jeremy Grimshaw's article published in 2003 in The Lancet of the current state of evidence for knowledge translation strategies. A few things I want to say about this. This is what I call the wave one of knowledge translation research, where a great deal of work was done, very good science, much of it with a focus on changing physician behavior, and subsequently we've done a lot of work in education and in the allied disciplines that has not been yet systematically reviewed. And what you can see here is how they've classified these KT strategies as either mostly effective, mixed effectiveness, limited, and some of the ones that I speak to in my training course that are not systematically reviewed as yet, although I understand that there is shortly going to be a systematic review of arts-based knowledge translation strategies. Next slide, please, 27. The way that I've conceptualized these strategies is in the following way. I have grouped some of them as role-based knowledge translation strategies, so these would include knowledge brokers, opinion leaders, consultants, champions, and something called substitution of tasks, which I will describe. So the next slide, 28, gives you a definition of knowledge broker. And I think of knowledge broker as both knowledge translation as a strategy of brokering, but also embodied in a particular role that an individual takes on, to link decision makers and researchers, to facilitate their interaction, to facilitate their understanding of each other's goals and professional cultures, and through this forging of new partnerships, promoting the use of research-based evidence in decision making. Slide 29 is an overview of opinion leaders, and opinion leaders are considered knowledgeable, trustworthy. They're champions typically from within the organization, although they may also be from outside the organization. The information you see below the image on the left-hand side is a synopsis of what is provided in the Groling-Grimshaw Lancet article in terms of how they made these conclusions. Substitution of tasks is something that is probably most easily described in thinking of a pharmacist who would typically package and dispense medications and may expand their tasks, not so much a substitution as perhaps an expansion of tasks, to begin to advise their clients, to work with other healthcare professionals, to work with the public. We probably all feel like our tasks have been expanded in the last decade or so. It seems to be a never-ending. But this is one way of sharing knowledge from research by having individuals expand their role to be the brokers of this information. Slide 31 is an overview of the organizational KT strategies, things like leadership, CQI, and financial incentives. On slide 32, you see some information about continuous quality improvement. Slide 33, not surprisingly, financial incentives are rather strong at encouraging practice change. We seem to like our money. On slide 34, I've listed some of the educational knowledge translation strategies: media, patient education, audit and feedback, patient-mediated knowledge translation, policy briefs, and clinical practice guidelines. And the slides that follow on 35 gives you an overview of educational materials. On slide 36, academic detailing, which is a highly used and effective strategy by the pharmaceutical industry, and essentially successful because it's about a person-to-person social interaction. It's a sharing of knowledge from one individual to another individual, and these two individuals have developed a professional and maybe even a friendship type of relationship, especially effective for improving prescribing behavior. Policy briefs are used still, probably not so much thought of as something that could be in the arsenal or the toolkit, rather, of researchers. But these are very useful documents for outlining a rationale for a particular policy direction based on research evidence. And written well, they could be very effective in brokering dialogue with policy advisors in government. Clinical practice guidelines, based from systematic reviews, one of the things that we've come to realize is getting the CPGs to actually be used in practice is another gap that we need to make. They are developed in a very rigorous way based on the best available science, but you end up with something of, several hundred pages often, which need to be distilled in some intermediary way where they can actually be used by people who are in the real world in the real time. On slide 39, we have audit and feedback. a way of looking at whether behavior change has actually occurred by doing an audit of some sort of either case review, it could be a client file, or just a database of types of diagnostic tests ordered, some way of actually demonstrating in an objective fashion whether the recommended behavior change for a particular type of behavior has actually occurred, and then feeding that information back to the practitioner. On slide 40, we have mass media, which has actually showed improvements in care and been highly effective. Slide 41 is an overview of technologically supported knowledge translation strategies, social media, reminders, patient-mediated tools, and clinical decision supports. On 42, you see an overview of reminders, so interventions that prompt the healthcare provider to perform a patient action or a specific action. On slide 43, there's an overview of social media here, so the use of flip to 44. You can see that Ed Bennett in the U.S. has been tracking the use of social media in hospitals for several years now. This is the latest evidence or the latest data as of October 19th, 2010, and quite an astounding number of hospitals using YouTube and Twitter, Facebook, LinkedIn, blogs, various social media strategies, mostly using them to push out information for educational purposes or as an addition to their communications toolkit, less so for creating dialogue between individuals or for purposes other than education or knowledge and information. On slide 45, you can see how the growth of hospitals using social media has occurred since July of 2006 until October 2010. Quite astounding. On slide 46, you have small groups and networks depicted here, so things like interactive workshops and communities of practice. Slide 47 is an overview of networks. Community of practice is discussed on slide 48. Essentially, community practices are really on the rise. They are groups of people with a common interest. We have studied communities of practice in our research team in a contrived way where they weren't naturally emergent. We actually brought clinicians together in practice to see whether it would have an impact on how quickly they would use a new evidence-based practice in which they were trained, and we were able to demonstrate that the community of practice did facilitate quicker uptake of an evidence-based practice. On slide 49, we have interactive small groups. Slide 50, multi-professional collaboration as another strategy. And then on 51, just a reference to arts-based knowledge translation that's being used both to create knowledge but also to transfer knowledge. It's bringing together the systematic and rigorous qualities of scientific inquiry with all different kinds of artistry. So it could be photography, it could be dance, it could be music, it could be poetry, narrative. Lots of different projects have been happening, for instance, in Toronto that I'm aware of, and it's a very big growing area of knowledge translation. And then, of course, on 53, the patents and commercializations, I also conceive of as fitting within the knowledge translation continuum as strategies. Starting with slide 54 and 55, I want to make a few points about stickiness because I want folks to consider beyond these strategies how we might be able to be a bit more creative, to tap into the right brain a little bit more than the left brain, and how do we make our messages that people will retain and think through? How will we make messages that will develop awareness and elicit an emotional response in people rather than continuously going for the intellectual response? And from here, I pull on the work of Chip and Dan Heath, who many of you will know for the books that they've recently written on stickiness, and their description of a sticky idea as being one that is easily understood, remembered, that changes opinions, behaviors, or values, and has a lasting impact. And they talk about 6 6 elements of stickiness. We had hoped that we could show you some video clips of some examples that I teach to people or show when I'm face-to-face with them, and we didn't think it would work in this format, unfortunately. But I would direct you to the Fun Theory, so www.thefuntheory.com, for some examples of how you might approach some public health issues that are have been with us for some time, so having to do with hand washing, having to do with exercise, and how they've come up with some creative, very right-brain strategies to change people's behavior. So the Heaths talk about the importance of simplicity, isolating your core message and conveying it succinctly. We often get too carried away with the number of messages we want to give people, and so they, what is your one core message? Having something of unexpectedness in your strategy or your messaging works very well as well, because it surprises people and creates intrigue. You want things to be concrete. You want your messages to be real and recognizable so that people can see exactly what would be required of them to adopt the information into their day-to-day thinking or their day-to-day practice. They need to know exactly, almost in a recipe-type way, what is expected of them. Of course, you need credibility, and we're usually good at that. What we don't do well in our messages is tell stories that evoke both the main message of our research finding, but also feelings about what really matters for people. And this taps into the importance of figuring out what is it about your research message that matters to your audience, and then telling that through stories, connecting the dots for people. I want to make a few points about implementation, so moving to slide 57, please. Dean Fixon talks about the variety of gaps that we have, and when we talk about knowledge translation, we talk about the science to service gap. So what we know in research is not what is adopted to help children, families, caregivers, or to use in whatever sector or area you're working in. But we also have implementation gaps. We know that what is adopted is not necessarily used with fidelity and good outcomes for consumers. Sometimes we adopt and we use things with fidelity, but we're not able to sustain that use for a period of time. And the third implementation gap is that oftentimes when we use something with fidelity, it's not used on a scale that is sufficient to impact social or health problems. And so as we move from the implementation of evidence-based practice from a practitioner to an organization to a region, we need to think about how to scale this up. And this is an important new area for implementation science as well. On slide 58 gives you an indication of what we know from some of the research about how important it is to have an implementation team. Remember earlier I talked about the importance not only of choosing good KT strategies, but of thinking through what the processes are going to be to implement them. Ballas and Boren in 2000, their work translated to saying something like it's going to take 17 years to get diffusion of research evidence into clinical practice. And even in that period of time, only about 14% of the evidence base will be taken up. The contention of Dean Fixon and his colleagues at NERN are that you would have 80% take-up of effectiveness and success if within a 3-year period of time. So the importance really of having an implementation team and an implementation process in order to realize your outcomes. On slide 59, we see how this translates into outcomes for student achievement when you have a staff development initiative underway. In this work by Joyce and Showers, they compared different types of support to teachers and what they would expect and what they were able to demonstrate that support actually led to in terms of knowledge acquisition, skill demonstration, and use in the classroom. So as you can see down the left-hand column, to train simply with a focus on theory and discussion leads to 10% knowledge uptake, 0% skill demonstration, and 0% use in the classroom. And as you work your way down to the last row in that column, when you have everything, including coaching in the classroom, you can realize 95% knowledge uptake, 95% skill demonstration, and 95% use of that skill in the classroom. So it has everything to do with the additional supports we provide in addition to that training portion, that portion where we think we're sharing the knowledge, we're telling people how to do it. One of the things, if you've done this before and you've tried to get anybody to learn something new, you will know in your gut that people need to see things, try them, and do so repeatedly. There has to be great redundancy and a paying attention to what kinds of supports and preferences people have for what kinds of supports they want, in addition to how you're going to measure that they actually are doing what they should be doing with respect to fidelity. On the next slide, page 60, is a summary slide that just brings home the point that with effective implementation and effective intervention, that's where you're going to get actual benefits. Slide 61 is a reference to the National Implementation Research Network Stages of Implementation, and they have a very nice monograph available on their website that describes these stages of implementation from exploration and adoption all the way to sustainability. These stages of implementation were derived from a very nice systematic review of diffusion and KT literature. I'm going to now go to the slide 62 and describe how we've taken all of this knowledge and reduced it and combined it to develop the knowledge translation planning template. Now, this template arose really for very practical reasons for myself initially, as I was being invited to participate either as a collaborator or co-investigator on research in health areas that were not my area. And so, a researcher contacting me within the Hospital Research Institute whose work is in the area of esophageal varices, which I actually had to look up to figure out what they were. The point being, knowledge translation core components and strategies for good planning are universal and can be applied to education, any area of health, social sciences, etc. But one needs to have an approach that will enable you to capture all of those core components, even if you aren't cognizant and fully knowledgeable in the health area at hand. And so I'm going to walk you through the KT template. In this slide 63, it's not readable. I'm pretty sure that Joanne and the folks in Texas will make the KT template available to you. It's also available at melaniebarwick.com for download if you don't get it in any other way. I'm going to take you through different elements of the template here. On page 64, the first thing you want to be doing, and this was really written, developed with the view that somebody would sit down to develop a KT plan for a research proposal. But you certainly could apply this for developing a KT plan for a project that wasn't going forward for funding. But given the context that it is for funding purposes, you want to identify who your research partners are. And on the form, it's a fillable form, and you can go through and tick this, or you can print it out and fill it in by hand. On page 65, in the second column of the template, you want to identify the degree of partner engagement that you're having. So from idea formulation straight through to beyond the project. This is the notion of when are you going to engage your partners and how engaged are they going to be? Joanne, I just want to make sure I still have you there.
Yes, I'm still here, and I think we're doing fine with time.
Okay. On page 66, slide 66 rather, identify the KT expertise you have on your team, whether it's a research team or a project team. Sometimes you'll have scientists with knowledge translation expertise, people who are KT or implementation scientists. It's not always necessary. It depends whether you are proposing a project that is focused on KT science or merely proposing a KT plan for another type of operating grant. Sometimes you can engage a consultant who has KT expertise. You may need a knowledge broker or a knowledge specialist. There are lots of terms for the same type of person. In instances where you may have a lot of target audiences, by a lot I mean at least 3 or 4, particularly policy, maybe other non-academic organizations where there's a lot of work to be done in developing relationships, sharing information, learning from one another. That may be too much for the principal investigator to take on themselves. They may also not have the skill set. They may not have the time. And also when there are many products that need to be developed end of grant for different audiences, you may want to engage somebody for a portion of your project who has this special skill set. Sometimes there are KT supports within an organization, and one of the things to consider is whether any of your partner organizations have KT supports available to you. That could be personnel, but it could also be websites or other means of accessing your target audience. Next slide. So here you want to describe what you think your main messages are going to be. Clearly, you don't always know, especially if you're developing this at the proposal writing stage. And so it's fine to say that your main messages will emerge, and they may be emergent because it's a process and because you're going to have engagement from your partners, or they may be emergent because you just don't know till you get to the end of the story. But you could write here what you anticipate your messages might be and what they might be for, say, up to 3 audiences here. In column 5, the KT audiences, you have an opportunity to identify which audiences you will target. And there are a series of choices here, but there's also an opportunity to identify an audience that I've not included on this form. On column 6 is where you talk about what KT goals you have in mind for each audience. So let's just say that one of your audiences that you've selected for your KT work, for your research, are other researchers. That's going to be audience number 1. So of those 3 boxes in a row, it's going to be the one on the left. And you're going to say, okay, researchers, what do I want to accomplish in sharing my research findings with other researchers? Well, I may want to generate awareness. I may want to impart knowledge and inform other research. So I would tick those boxes down the left foremost column under number 6. Another audience may be healthcare practitioners. I want to share my research findings with healthcare practitioners. So that's going to be audience number 2 for me. And what I want them to understand, let's say I'm working on the importance of assessing pain and managing pain in pediatric healthcare facilities, some of the research that we're doing here with Bonnie Stevens. We want to generate awareness for healthcare providers that there are methods for assessing pain. There are ways of managing pain that are probably broader than what they were aware of. We want to generate an interest in them for perhaps moving towards practice change and using some of these methods. And, that might be it. That might be our goal for that audience, and so on. On slide 68, we have 3 of the next columns from the template. The first, column 7 here, are the KT methods. And this is not meant to be an exhaustive list. We've simply tried to fit what we can on the page. And the reference here are the evidence-based knowledge translation strategies from the systematic review produced by Richard Grohl and Jeremy Grimshaw. So the most effective, the mixed effective, and so on and so forth. And you have an opportunity to identify what methods you will use for the 3 audiences that you've identified. In column 8, you want to make some reference in your description about what your knowledge translation process is going to be. The language used here in Canada, promoted by the Canadian Institutes of Health Research, is sort of a distinguishment between integrated knowledge translation and end-of-grant knowledge translation. The simpler one, end-of-grant, is really what are the KT strategies you're going to undertake at the completion of your research process. Journal publication, workshop, conference presentation, research brochure, consensus building, conversation meeting, all sorts of things you might do at the end, when you know what your findings are. Integrated knowledge translation really pertains to the more participatory work you would undertake with researchers and research users together who would collaborate, might shape the research process together, they might look at preliminary research findings together, and together they may come up with what the best knowledge translation audiences are and how the best methods and timing may be to reach them. So it's much more of a participatory approach. In column 9 is KT impact. Where do you want to have an impact? So if you follow through to the audience you identified, the KT goal for that audience, the methods you're going to use for that audience, what process you're going to engage in, what do you want at the end of the day? Do you want to have an impact on research, on health policy, on practice, on health outcomes, and how are you going to evaluate that impact? It's a little limited here in the sense that we've pulled from that earlier logic model and resource for when you're producing research services or products, for instance. So, what might be some reach indicators if you're going to distribute information, how many downloads, what kind of media exposure are you going to have? You may want to be looking at things like usefulness indicators for products that you have put out there that have summarized your research. So one of the things we frequently don't know when we put information out in written form or even in any other form is whether people actually read it. Did they open it? Did they look at it? Did they read it? Did they talk about it? Did they reflect upon it? Did they share it with anybody else? Do they intend to do anything with that information? Those are the things we never know unless we go back and ask. And so there are a couple of other indicators listed in this section of the template. On slide 69, you get into the last grouping. Column 10 provides an opportunity or a space on this template where you can talk about what is your partner's role in the KT strategy. And this is important, particularly where strategic funding opportunities ask the researchers to describe not only, well, sometimes they're actually asked to involve partners, decision-maker partners, and that's a strategic, I was going to say ploy, but a strategic driver or activity to encourage participatory and integrated knowledge translation. It's quite good, I think, to do that. But you want to be able to describe not only who your partners are, but what are they going to do? What is their contribution to the overall research project and to the KT plan, and what are they getting in return? And oftentimes partners are asked to write letters of support where they can describe this information, but it's definitely useful as you talk about who your research team is to go beyond explaining or describing who your research team is to who the wider team is that you're going to involve in your research program. In column 11, you have an opportunity to identify what resources would be required to implement your knowledge translation plan. And as we all know, those of us who have done this before, it's always good to think of the budget items before you get the money and not leave out important things. You can identify what related budget items there are for your project in column 12. One of the things that I do frequently, a research funder will have formulated modules or templates for how to describe the budget for your research project, but they often ask for a justification. And in the justification addendum that I provide, I always have a section for knowledge translation expenses. It helps me to ensure that I've covered them all, but I think it's also important to signal it out for the research funder that a portion of the expenses or the costs that you have requested are for these types of activities. And then you can do some work offline to think through what estimated costs would be for different sorts of things. And you can talk about whether a separate knowledge translation grant or other funding opportunity will be sought to conduct some knowledge translation activities stemming from this research. In Canada, through CIHR, we have that opportunity to apply for dedicated knowledge translation funds to expand on KT strategies from an operating grant to run meetings or have planning meetings or dissemination meetings, and that's a very important opportunity to have. I think it really helps to support the development of knowledge translation research across the country and has been an important driver for getting us to this point. Lastly, you want to describe on slide 70 how you will implement your knowledge translation strategy. So what's the process involved in applying your KT strategy? And how are you going to know that you transferred your information with fidelity in a quality-driven way and that people are actually, that you've actually accomplished your knowledge translation goal? And again, there are no sort of little tidbits I can tell you about how to go about doing that. You're going to need to think that through as it pertains to your specific project. And lastly, on the last three slides, 71, 72, 73, I've provided an example. It's not entirely fleshed out, doesn't have all of the columns, of a knowledge translation plan developed by Anna Taddeo, who's a pharmacist here at the Hospital for Sick Children and has been doing research on pain management of children during routine immunization. And just to give you an idea of who she set out as her target audiences, how she described they would be engaged, what main messages she set out for each audience, the KT strategies that she and her team would implement to address those KT goals and share those messages with those audiences. And so, she identifies quite a lot of audiences, and that can end up, the conundrum is that as you develop the KT plan for an operating grant that's maybe not about knowledge translation science, you end up doing a mini baby project at the end of it all just to implement your KT strategy. And so you really need to balance out how many audiences can you target, what can you accomplish within the constraints of your time for your funding and the amount of money you have and the effort that you're willing to put through. I've known several researchers here at Sick Kids who've actually moved from more epidemiologic type of research after 15 to 20 years, realizing that the research is not making its way to the intended audiences and not having the benefits it was intended to have, to refocusing their entire research programs to implementation science and not so much to discovery of the disease or its basic components or even its treatments, but knowing enough about these areas, how do we get that information out there? And so that's a direction that many seasoned scientists are taking. Lastly, an opportunity for self-promotion on slide 74, where we have an upcoming scientist knowledge translation training for external non-Sick Kids participants. There's still room for this training, and the contact is at the bottom of the page there. And then on slide 75, just an overview of the most recent addition to our training menu, which is the Knowledge Translation Professional Certificate. We had our inaugural class January 17th. It's a 5-day course here in Toronto for 15 people, and it was hugely successful and very well received. And so we had hoped to run our second installation next January, but we've been oversubscribed already, so we'll be holding that in October this coming fall. And with that, I'm going to stop talking and leave a little bit of an opportunity here for questions. Thanks, Joanne.
Thank you very much, Melanie. You really covered a lot of information about planning for knowledge translation. When I saw your slides, I thought, how is she going to do it? But you did a great job. Thank you so much.
I always think, how am I going to do it too? And then I actually make it through, so you're welcome.
Well, you really did a good job. We do have a couple of questions that have come in from our audience, so let me read those out. As you mentioned, there may be multiple audiences involved as end users. In realms outside of medicine, these multiple audiences can have different or even directly contradictory agenda, missions, and sense of what is a desirable outcome. How can you address this situation?
It's hard to give a specific answer because that's sort of a general context. I think first and foremost, while you need to consider how to tailor your messages to your audiences and how to choose what might be best received by them, that is to say, what information are they looking for to help with real-world issues, first and foremost, you need to be true to the evidence. When I say tailor a message, it doesn't mean change the results. And so it's a bit of, it's a negotiation, if you will. Most of the time when you're sharing your results with multiple audiences, you're dealing with those audiences one-on-one. Rarely are you seated at a table with all of them and their competing interests, although that may very well happen. And so the task for the researcher and the research team is to get to know that audience. What are their sticky issues? What are their biases? What is it they want to see have happen at the end of the day? And it may very well be that the research evidence you have to communicate to them does not support their intended direction or the messaging that they want to convey, and you got to stick to your guns. They didn't commission the research. They are a valid knowledge user, and while you can pay attention to what you share with them, how you share it, when you share it, and what messages you think that have come from your research will be most pertinent to them, there's very little you can do with an audience that's not receptive because the messaging didn't go the way they had wanted it to go.
Thank you very much. Here's another question that actually I think kind of fits well with what you just said. This actually goes back to slide number 10. Excuse me, and that was the audience increasing utilization. And the question is, do you find that researchers pay sufficient attention to the decision-making and funding cycles of organizations they are hoping to influence? For example, if a researcher has compelling evidence for practice change, but the organization's program decision-making and or funding windows are too far in the future, adoption of the practice change may be deferred for purely administrative reasons.
That's absolutely true, and that's a real-world issue we all have to contend with. I've butted up against this particular conundrum, if you can call it that, with my interactions with senior policy analysts and bureaucrats in the Ministry of Children and Youth Services here. They are the funders of provincial child and youth mental health services. It does happen that you have message to share that may not sit well with their timing because, they need to do things very quickly, oftentimes within the space of 24 to 48 hours, and we certainly don't have a research or knowledge production cycle that even approximates that. So sometimes we don't have the evidence handy. Sometimes we may be reluctant to share other people's evidence, although that's a good thing to be doing is, when you're building relationships with policymakers, you want to be a conduit to the research evidence base, whether it was produced by you or by other colleagues in your area. That's good relationship building. But I have shared information that perhaps doesn't sit well with the priorities in this strategic plan for a government department or ministry in Canada. And my advice is to sit tight. I think if you have a good relationship with your end user, whether it's in policy or in another organization, that means that you're going to have frequent, maybe intermittent, but occasional opportunity to communicate with one another. You may propose a 3-pager of a research project that is relevant to them, largely speaking, but perhaps not something that they can direct their attention to right now. Maybe they have fires to put out. Maybe there are political decisions being made. There could be all sorts of real-world issues impeding on their ability to take notice of your research plan or even your research findings. But if you have a relationship with these individuals, you can resurrect that information. It's very similar to bringing the topic up in another conversation at another time. You also, through that relationship, will have a better sense of what's going on in that organization in terms of political tone or other kinds of issues that they might be contending with. So it gives you some information about when to make your pitch. Maybe you hold off for a while until things calm down, and then you have an opportunity where you'll have better receptivity and perhaps better readiness to hear your messages.
Great. Thank you very much, Melanie. That was an excellent answer. This question I think you've touched on a little bit, but I'm sure everyone would like to hear you talk a little bit more about what might be called the KT brand. The question is about terminology. What is the relationship of KT to implementation and dissemination sciences and other terms that are used internationally referring to research to action processes?
That's been coming up a lot in lots of meetings lately. You know, I have a slide, of course I didn't include it, would have been useful in retrospect, which kind of groups these different labels together. I kind of group together things like knowledge translation, knowledge transfer, knowledge translation and exchange, knowledge mobilization. Those for me mean the same thing. It's really about bringing science to practice in ethical ways, in ways that are applicable, in ways that can be used to improve health or other kinds of outcomes, just as a summary. They all mean the same thing. Related to that are knowledge brokering, and then implementation, reach, diffusion are related terms that mean something a little bit different in the sense that they are all functions within the knowledge translation continuum, if you will. Implementation is, I think, synonymous with knowledge translation. You can call it knowledge translation science or implementation science. The difference being, I think, that knowledge translation science seems to hearken to what I call the first wave of KT research, where we did a lot of try this strategy, sit back, see what outcomes we get, and report them. Implementation science and the use of that term seems to hearken for me more of the attention to the processes involved. So when you applied that KT strategy, what actually happened? How did you do it? It means paying attention to things like context, other factors that we know are important, readiness, leadership, etc., features of the actual innovation in terms of its observability, its trialability. It really speaks to that messy part. I mean, implementation science is messy. It's really hard to make sense of all of the variables that seem to be important when we're implementing and when we're studying implementation. It's sort of what I call wave 2 of knowledge translation research, because now we have moved away from thinking that the randomized controlled trial that is doesn't pay attention to, doesn't mean it can't, but ones that have been conducted that don't pay attention to contextual issues or factors and other kinds of factors in terms of process and implementation and fidelity didn't tell us the whole story. So now when we talk about implementation science, we may be using RCT designs, we may be using mixed methods designs, quasi-experimental designs, and they may all be the best design for the question being asked. But now we're having to pay attention to a whole lot of other factors that perhaps we didn't pay attention to before. The terms that I think are used that mean something different are things like knowledge management. And knowledge management is not irrelevant to what we're trying to work with when we're doing knowledge translation and implementation, but it has to do with how do we manage knowledge within an organization. And it's typically a term used in the private sector to talk about how do we manage knowledge to increase our return on investment. And so when I think of knowledge management, it means something else for me than what I'm referring to in knowledge translation or implementation. The other term that I think is somewhat different that stands alone is translational research. And translational research, translational medicine, is a very medical model piece of KT. It also sits under the continuum of knowledge translation, but it really has to do with bench-to-bedside sorts of applications to improving clinical practice, development of technological devices and this sort of thing. And then I guess the last piece that I also think means something else unto itself, but still sits under the umbrella of knowledge translation, is the whole patenting and commercialization aspect. When you think globally in terms of terminology, it's important to recognize that knowledge transfer means something different here in Canada and probably the U.S. than it does in Europe and the U.K. In the U.K. and Europe, knowledge transfer really has a lot more to do with building linkages between between universities, academic institutions, and industry, with the sole purpose of developing commercialization activities, small to medium business enterprises, and bringing money back into the university. That's activity that we undertake here in Canada and the U.S. as well, but our scope of how we perceive knowledge translation and implementation is much broader in terms of other audiences and other activities. I'm going to stop there and hope that answered the question.
That was excellent. It sounded like you had that one prepared, I'll tell you. So I can tell you have been talking about people with that around that particular topic. Our next question is, can you describe what are the best KT strategies to affect policymakers trying to increase the utilization, for example, of disability research evidence in new policy development or reauthorization processes?
Wow, that's a toughie. Okay, it's going to sound a bit glib. What I have found most useful in influencing the use of evidence for policymakers is a relationship with the policymaker. Now, that's a bit challenging, and I can tell you from my personal experience in managing an outcome measurement initiative for the province of Ontario in the last 11 years, I probably have had to develop a relationship and ramp up a new lead from the ministry side about 12 or 13 times. So it's not as though over the long term the person with whom you can have the best influence within a government office or policy office is going to remain to be the same person over a period of time. That's a challenge that we all have to deal with. But really, I can tell you, because I've had experience in developing these 12 to 13 relationships over the last 11 years, that when I have a good personal connection with a policymaker, when I have something to say that's evidence-based, that is consultative, that is informative and intended to benefit decision-making that they're undertaking, I get further, and they get further. I think they are more inclined to listen. They're more inclined to understand what it is you're saying because you've developed a relationship, you understand each other, you talk the same language, and there's a feeling of trust there that they can take that information. They understand who you are as an academic, as a scientist, as a person. You're credible, you're trustworthy, and, in the high-risk environment that is policymaking where no one wants to take a risk, that counts for a lot. I think that's one strategy, if we can call it a strategy, in terms of the brokering and the relationship building that really sets the stage for the knowledge sharing that needs to occur to influence policy. The other two things I would have to say about influencing policy would be educating researchers about policymaking environments. This is a component of our training that we've always included, and I would have been in the same boat 10 years, 11 years ago had I not had experience in working year after year on projects involving government. But most researchers in all fields have absolutely no idea what the life of a senior policy analyst is, or anybody in the government, what their world is like, how quickly they need to jump, what the influences are, why they may not be able to be as forthcoming as you'd like them to be, which can be very frustrating at times, how politics plays a role. And so I think to develop a cadre of researchers who understand and are familiar with the world of policy is an important, it's maybe not a KT strategy, but it's really foundational. It's really important in order to be effective with that audience. And I guess the third KT strategy I would think of for influencing policy does not exist separately from that relationship I was speaking about, but to learn how to develop a very tight policy brief as a KT strategy is a good skill to have. But you can't simply develop a good, even if it's an excellent policy brief, really well written, really well substantiated by research, laying out 2 to 3 avenues that the government can decide to take to resolve a particular issue that is highly relevant, politically charged for them at that particular time. That's really going to be no good in and of itself unless you have a relationship with somebody where you can hand that over, you can talk through it. It's kind of hard to cold call a policy brief when there isn't a relationship there and try and have it mean anything or have an impact at all. And I hope that makes sense.
I think so. That was an excellent answer. Thank you. We're just about getting close to the end of time here, but we've got one more question. Maybe you can squeeze this one in. Questioner says, you mentioned the possibility of pushback from some researchers who are not as open to incorporating user needs into their research plans. What are some good strategies for overcoming this researcher resistance to KT and KT planning?
Wow, I've kind of stumped now. That's my last question. I guess our strategy here at SITKIZ is to develop training to help scientists learn about the importance of KT regardless of their area of inquiry, and how they can incorporate those strategies to ensure that their research actually has the intended benefits. So I think educational approaches and KT training go a long way to getting people to shift their attitudes and perhaps be a little bit more aware and ready. It also goes some distance to negating some of the myths, I think, that have popped up over the last several years. I mean, you know, I've trained scientists across all pillars of health research and educational research and agricultural research and social sciences. So, you know, in the health sector, everything from basic science all the way up to population health, including clinical and health services research. And I've not come across one scientist, even the cell biologist, who can't say that there's more than one audience with whom they wish to communicate. So, you know, that's what it's really about. It's about expanding the impact of your research findings. And sometimes when really your focus is on other basic scientists, perhaps the reach for you is to go to basic scientists who are in adjoining areas or disciplines where perhaps you might be able to propel each other into new thinking or new research areas. It might not be someone down the continuum closer to clinical application or even health services application. It might be someone who's still in a basic science area that you need to communicate with. And when you start to push people to think about, what do you want your science to do? What is it you're doing every day when you come to work? What do you want to accomplish? What do you want to contribute? And how are you going to do that? How are you going to know you did it? Most people can follow that sort of conversation and say, well, this is what I'm studying. This is what I hope it will accomplish. And in order to do that, I need to be able to communicate that to, you know, maybe a small group of people, but it's more than other scientists. And most basic scientists will acknowledge that. I'm suggesting that the pushback has come mostly from basic scientists early on, particularly when our research funder started to, you know, make requests for KT plans. People used to think, well, you know, the other pushback is you're already going to cut my research budget. Now I'm going to need to take a portion of that and apply it to a KT plan, and that's probably the first thing I'm going to dump when you cut my research budget. And so there are real-world decisions to be made based on constraints that are financial and time and so on and so forth. But I think a good conversation, some training, some recognition that, not everyone is intended to include policymakers and decision makers as their audience. It really has everything to do with the work you're trying to do and the relevance the audience have to that work. No one's expecting a cell biologist who's looking at, how different drugs cause death or protect different cells to be talking to policymakers. That said, it is useful for all scientists to be able to present a business case and talk very plainly about what research they do and why it's important. We're very quick to introduce ourselves with, jargon language and reference to our various titles without really explaining to people, here's why I think it's important what I do, and here's how it's relevant to you. And we're not so good at doing that, and we need to improve.
Thank you very much, Melanie. I really appreciate the thoughtful answers you've given to these questions. And we have run out of time. We've had a couple other questions come in focusing on the issue of evaluation and measurement of outcomes and utilization after your KT processes have been implemented. But I can tell that might be enough for another whole webcast in the future. I want to see if you have any other final comments that you'd like to make before we wrap it up.
I'd just like to thank everyone for phoning in today and for the opportunity to present some of my ideas and the work that I've been doing. It's been delightful from my perspective.
Well, thank you very much. We really do appreciate your time and effort today. And I want to thank everyone for participating in this afternoon's online workshop webcast. And now I'd like to remind and encourage everyone to fill out the brief evaluation form. This will be very helpful to us for planning future events, and it just takes a minute. You can do it right now before we sign off. Just click on the Downloads tab at the bottom right-hand side of your Windows Media Player or Real Player screen, and you will see a direct link to the evaluation form. A link to this evaluation is also found on the NCDDR's webpage for webcast number 30. If you find you can't access the evaluation form right now, there may be too many people all trying to access it at once, so please just try again in a few minutes or maybe tomorrow. In the next few days, we will have the archived audio-video file and a written transcript of the webcast available and posted on our Webcast 30 page. I will send an email to everyone who pre-registered when these items are ready for review. And I want to let you know that our next webcast will be taking place next Wednesday, March 2nd, at this same time. Our presenter will be Mr. Joe Lane, Director of the Center on Knowledge Translation for Technology Transfer at the University at Buffalo. He will be discussing 3 states of knowledge and their implications for innovation policies. Please visit our website at www.ncddr.org for more information and to view additional archived webcasts on topics related to knowledge translation. Again, thank you so much, Dr. Barwick, for your time today, and I want to thank the National Institute on Disability and Rehabilitation Research, NIDR, that has provided funding for the webcast. On behalf of our speaker and the rest of the NCDDR staff, thank you and good afternoon.